그래서 타이틀이 그림을 잡는 미션을 스타트했던 거죠. 나라 버스 빨리
이 스피커를 꺼야 돼.
Okay. Hi, my name is Hanjin Park, and today I'm going to tell you about septal puncture. Because of the new fellows, and as well, I'm not sure I am doing septal puncture well, so I've studied and tell you and share the things that I have seen. This is the flow chart of this presentation. And first, in order to perform septal puncture, you have to know the anatomy of the right atrium. If you see this picture, it is in the RA view. So you can see the SVC and the IVC flat cable line, and you can see the fossa ovalis here. Septal puncture basically engages from the SVC and downward to the fossa ovalis. And you can see other structures or other related structures here, such as tendon of Tobaro and coronary sinus, the Jefferson valve, and tricuspid annulus. If you see this picture, one thing you have to keep in mind is that RA and LA is not a square-like structure that faces the plane together. So it is this narrow point where you have to aim, and there are very many hazards before you can perform transseptal puncture. And you can see interatrial fold here, which you can go into during the septal puncture, which I will tell you with the following pictures. As you see here, this picture emphasizes the importance of interarterial fold. Yes, so this picture shows you the importance of interarterial fold during septal puncture. So I will illustrate it as a simple picture in the next slide. As you can see here, if we imagined as a starter in EP, we imagine that RA and LA is a square-like structure that faces each other, but the fossa ovalis is a point-like structure with very dangerous hazards all around. So you have to know how to perform septal puncture safely and with the anatomic landmarks in mind. This angiography illustrates you about the previous mention that I told you. So this is the RA and LA, in which there is a fossa ovalis, and septal puncture has done, but there is space without square-like structure facing each other. There are several landmarks for transseptal puncture. Usually, we don't put a pigtail catheter in the aorta, but several EP catheters can show you where the aorta is, such as quadripolar catheter in the His area, which represents the membranous septum between RCC and LCC. And also the catheter in the coronary sinus shows you another landmark, which I will illustrate in the following figures. If you see in the LAO view in the left picture, there is a pigtail in the aorta, which corresponds to a quadripolar catheter in the His area. If you see in RAO view, this becomes more obvious, in which membranous septum of the RCC and NCC corresponds to the quadripolar catheter. So this is where the aorta is, you can think. And also, CS catheter is another landmark. I will illustrate you this point in the following figures as well. During the transseptal puncture, transseptal needle, we usually use BRK. Although we use BRK, but we can manually adjust the degree of the angle of the transseptal puncture. And before we perform transseptal puncture, we usually, in case of AFib, we usually do the CT scan, and we can adjust the angle of the transseptal needle according to the CT. This is the apparatus of the transseptal puncture equipment. This is the BRK needle, and this is the dilator of the SL sheath, and this is the sheath. So all these three apparatus aligned together, you can see in the bottom picture, in which the pointing should be aligned all together, and the apparatus will point to the same way, same direction. Firstly, before you perform the transseptal puncture, you engage the brachiocephalic vein with the guide wire at the PA view, and you put the guide wire in the brachiocephalic vein, and through that guide wire, the SL sheath goes up into the brachiocephalic vein. And after you remove the guide wire, you descend your transseptal sheath apparatus at the LAO view. The one important thing is that the tip of the apparatus that I've told you previously should be 5 to 6 o'clock direction, as you can see in this picture. And usually the radial pack line here is not deviated. If you see it is deviated, then the pointing of the apparatus might not be at an appropriate angle. With the pointing of the apparatus at 5 to 6 o'clock, you will descend the apparatus through the SVC into the RA. As you can see, the brachiocephalic vein is about here, and you descend your apparatus through the SVC. And SVC RA junction, if you wait a little bit, the whole apparatus goes 1 point about in the medial side, which represents that the apparatus has moved from the SVC to SVC-RA junction and RA. And you will see another pump this is the first one, medial movement, and you see the hump there. That's engagement in the RA to the fossa ovalis, which you can see in the picture in the right. So this is the SVCRA junction, and medial movement when the apparatus goes into the RA, and a hump, second hump here, which you will see as a more medial positioning of the septal puncture apparatus. After descending of the septal puncture apparatus, you have to see whether it engages the fossa ovalis. You have to confirm. One thing is that I don't have many experiences, but most useful thing that you can confirm whether you're in the fossa ovalis is in the RAO view. You can see that the coronary sinus catheter and the transseptal apparatus moves together. If these two move together, you can say that you're in the fossa ovalis. And in the RAO view, you can adjust your apparatus, whether you want to puncture in the posterior or anterior. This is the box where you should aim for transseptal puncture. This is from picture from the journal, but first I'll explain. You see the pigtail catheter in the aorta, which represents the aorta. This can be substituted to the quadripolar His catheter. So the septal puncture aim should be posterior to the His catheter and should be superior to the coronary sinus catheter. And this D line represents the contour of the left atrium, but there are some catches here, which maybe some people with RA enlargement or pericardial effusion, those contours can be deceiving. So after you engage the fossa ovalis and check the anatomical landmarks, such as in the picture in the middle, you see this coronary sinus catheter and the His catheter, which you should aim for the posterior to the His catheter, and you confirm that the septal puncture apparatus is moving with the coronary sinus catheter, then you are ready to perform septal puncture. But before that, in order for the procedure to be easy for catheter manipulation and ablation, you should adjust whether you should perform anterior puncture or posterior puncture. So you should clockwise torque to get the septal puncture apparatus in the posterior side. And you have to counterclockwise to puncture the anterior side. In my case, I always septal puncture in a view that the coronary sinus catheter goes away from me like this. Not, this is the very oblique X-ray, but I always do it in this configuration in which the coronary sinus catheter goes away from me, because as I said earlier, some people have distorted cardiac anatomy, or there are situations in which RA enlargement or pericardial effusion. So in this RAO view, those cardiac control might be less deceiving if you puncture in this configuration. For the AFib ablation or pulmonary vein isolation, we usually perform posterior inferior puncture in order for the catheter to contact the left pulmonary vein. But we usually perform two transseptal punctures. So for the posterior, should that posterior puncture, that will be easy for you to contact the left pulmonary veins. But in order to contact the right pulmonary veins, the second puncture should be a little bit anterior, so that clockwise torque, anterior puncture and clockwise torque, will enable you to contact the right inferior pulmonary vein. After the transeptal puncture engages the fossa alveolus, and you see this RAO and areal view, and after you have checked all of the anatomical landmarks and aimed for, you're gonna perform transseptal puncture. Just to remind, we usually perform transseptal puncture in the LA control and coronary sinus catheter. And the posterior 1/3 is the usually the site in which the catheter might contact well for the left pulmonary vein. After the transseptal puncture, this shows you that through the transseptal puncture PRK, contrast is injected, and it soon dissipates away, which tells you that the catheter is in the LA. If it is not in the LA, there will be stainings of the pericardium. But in this picture, you can see that the contrast dissipates away. Before transseptal puncture, you can, although I have told you some of the landmarks and the rules before transseptal puncture, you can confirm that you're in the fossa alveolus using contrast. If you see in the right picture, you can see that the contrast is stained in the fossa alveolus, which represents that you are in the right spot. Another, you can confirm that you're in the right place, you're in the LA, is that you can see the pressure monitoring, which the descending from the SVC to RA, there will be minimal or no pressure. but as soon as the transeptal puncture is done, LA form of the pressure monitoring will appear. After transeptal puncture, the sheath and the dilator will go through fossa ovalis and go into the LA. One thing you have to be cautious is that if you posterior puncture, your transeptal sheath might contact the posterior of the LA, which might damage the left atrium. After the dilator is in the LA, you hold your dilator and just put the sheath in. And as soon as the sheath is in the LA, you'll pull out the dilator. Yes. Using all of the information of using the landmarks and the transeptal apparatus and the coronary sinus catheter moving together, maybe contrast injection. If you cannot confirm that you're not in the LA, you should never advance your SL1 sheath because that can lead to hemopericardium and cardiac tamponade. Transeptal puncture is relatively a safe procedure, but there are some complications that we can think of. If you see here, in the left picture, you can see dye staining in the pericardium. And if you see in the right picture, this is very very severely the dye injected into the pericardial space. One thing that I have learned is that if you try, as a beginner, if you try to septal puncture too posterior, that might happen because the thing is that LA structure and anatomy is very different from individual to individual. And some people have posteriorly directed LA morphology. And if you see in the X-ray RAO view, if you aim for too posterior side, you might go into the interatrial fold. And if you go into interatrial fold and put the sheath in, you might have this kind of consequences. So before you go for transeptal puncture in the AFib procedure, I always check for the CT, which the right inferior pulmonary vein is too posteriorly directed. If I do not aim for too posterior septal puncture, because those people are likely to transeptal puncture in the interarterial fold if you aim for too posterior. Yeah. This is transducer puncture at the aorta. As I told you before, one anatomical landmark is the His catheter. His catheter represents the aorta. So if you aim for two anterior puncture, aortic puncture is possible. This is especially true because you usually perform two thrust vector punctures. One aims for the posterior and one aims for the anterior. But as a rule, the puncture site should be posterior always to the His catheter. This is not sure where the puncture site is, but it might be ST junction.
Do you know the result of the fate of
Fate
patient?
to follow.
What happened to the patient
Fate.
after this event? You don't know.
Yeah. This is just example, but there is the fate publication about the fate of these patients.
So what do you do when that happens? That would be more important. You know what to do.
Yeah, I will.
I mean, complication everybody has, okay? The complication is not a excuse not to do patient care. Question is, if that happens, what do you want to do?
So there is no much publications regarding this event, but
Okay.
there
Okay.
is one or two.
Yeah.
So this is one of them. And it depends on where the aortic puncture was made.
Okay.
If you see in this right picture, level 3 is through the pericardial space to the ascending aorta.
Okay.
And level 2 is not through the pericardial space, but through about the ST junction.
Okay.
And number 1 is more below.
Mhm.
So the fate of these three is very different.
Can you tell difference?
Yeah.
How do you know difference?
The thing is that if the puncture site is below the if the puncture site is the ST junction or RA to NCC, which was level 1 or level 2, there was no tamponade according to this publication, which you can see in the figure C. After the puncture and the dilator is moved, there was no or minimal staining in the pericardial space.
They did the TE, is what they did? What they
Yes.
did?
They just conservative management. And
No, how they diagnose these things, I mean, so how they diagnose what's the level what? By TE or by intracardiac echo? What do you use?
they confirmed it using the TEE, and after removing the dilator, they watched whether there was extra extravasation, but they found that puncture at the ST or RA to NCC level, there was none. But if you see here, if the puncture site was superior to the ST junction, you can see that there is a staining right after your dilator is pulled back from the puncture site. And this subsequently and almost immediately led to cardiac tamponade. So all of these, not all, but majority of these patients went under surgical repair. So before surgical repair, they put the sheath in so that cardiac tamponade does not progress. And even though they underwent urgent surgery, by putting the SL1 sheath in, they had stable vital sign before, during the time to the surgery.
In other
So
words, you're not removing your sheet.
yes,
That's the key.
Yeah.
Now I want you guys to know.
they all went into the operating room with the sheath in.
Second thing is that that helped the surgeon to control breathing much quicker. The surgeon will do the hemostatic suture around the sheet, pull the sheet back, and he just crawled up there. Couple of stitches, you're done. Okay, but since you don't know exactly where you puncture it in the aorta, doesn't matter whether sinus valsalva, a little bit above, even higher. They leave the sheet in, don't take it out, watch it. Call the surgeon, make a combined decision, never yours. Because if you have to go to surgery, whatever the reason, you have no way to handle. Only surgeon can handle. And also surgeon hate that when they try to find the hole because he cannot see it. So that delays the surgery and many other things. The bottom line, when you puncture the aorta, hopefully not, but if you do, leave the shit in, take a picture, call surgeon. Okay? Now you guys use often intracardiac echo now. So you can precisely tell where the hole is. But even then, do not take it out the shit. Because surgeon need to know where it is in case patient converted to the hemodynamic unstable condition. Okay? So that is a message. And I know they are writing this rare cases. These guys don't have enough experience on this. They just based on a few cases based on the they're writing this. So this is pretty much the restricted information for certain circumstances, but do not apply in general. So when you read the paper, you read it carefully. What this means to us, okay? First of all, transeptal puncture in air puncture is very rare these days. You guys use all echo, intracardiac echo, and so forth. Might happen in the people who under 3D, 2D issue. But I think if you really do pay attention carefully, in a transeptal puncture, the way before we do intracardiac echo, and it's a relatively safe procedure if you follow the standard protocol, and then I don't see much issue, okay? And then your imaging and the same image that you did showing us. Can you go back there? I want to point out something quick for you. No, that before that one, you had the real-time image there, yours. I don't know who that was. It's this one. I want you to look at that sheet. What is that around the sheet? What is leaking there? You see that dye leaking right around the sheet? Look carefully. Continue play right side. Out of view. Out of view, the best view. Keep playing that picture. Yeah, that one. The right side picture. Yes. Always look out of view. What do you see? Dye leaking back to where? You said you did not know where the puncture was. Where you think it is leaking backward around the sheet. Look carefully. There's something coming out. Yeah, right there. So it is important to know whether the dye contrast coming back to you or not. If it's coming back, need a surgery. Okay, don't play with that. That's the one tip that we always watch for. Because you can see already reconstruct the valve there, it's just above the valsalva. That one. You don't want to touch that shit. Just let the surgeon handle. Even though it does not leak, I don't think you want to pull it off. Okay, well, I'm sorry to interrupt you.
Yeah, there is two other difficult transeptal punctures, which is aneurysmal and fiber optic septum, fiber optic fossa. And thickened septum. There are reports that RF needle is okay. It is good for these complicated septums, but well, our RF needle is not like routinely performed, so In my case, transeptal needle stylet through the BRK back and forth helped during thickened septal punctures. And on some aneurysmal patients, if you push your septal puncture apparatus, the distance between the LA wall and the apparatus will get shorter, and sudden transeptal puncture might damage the LA walls. You should keep this in mind. You have some situations in which you have to perform septal puncture in the ASD closure devices. Although the ASD closure devices, it is usually safe to septal puncture through the closure device, and there were several and many publications using the unclutcher. So that the publication suggested that if the SE closure device is below 26 millimeter, you can safely puncture in the posterior inferior of the negative septum. And if it is 26 millimeters above, you can just transeptal puncture through the closure device. This is the conclusion. You have to deaerate and flush, and you should keep in mind of the landmarks, and just verify whether you're in the LA or not, and don't push the sheaths or the apparatus into the LA, push in if you cannot confirm you're in the LA. This is the end of the presentation. Thank you.
Foreign fellows, any question about transeptal? Can you go back your slides? Or first, let's go quickly through something that you may want to complement to make sure that we understand. Okay, so the anatomy is fine. Let's go. Now, one second, go back there. If you look at the, do you have a pointer, someone? If you look at this anatomy here, there's right at the SV junction, another crevice is right around the I'll just point, which is important. If your transeptal is coming out of SVC, we'll have a first jump into this guy here. This is the crevices. Quite prevalent in every patient. For some patients, very pronounced, very deep. The SVC coming down, suddenly it jumps in. So you think that's also bad. Be careful. Okay? Make sure you don't get in that trap. If you poke there, you will have what you see in the picture. So this is one of the areas that you really want to make attention. Go next. Keep going. Okay, keep going. It's fine. So keep going. Keep going. Yeah, you had a picture. No, keep going. This is you had where the needle engaging to the septum. Keep going. Yeah, keep going. That's good. Okay. So fine. Okay. Right here. You pass it. Okay. The reason we, nobody does really have to put the guide wire into the left brachiocephalic vein. You don't have to, unless you want to exchange the dilator in there and the needle in there. The reason is that you don't want to poke sharply forward. So subclavian veins is SVC basically straight up. The left side is match the natural curvature of the skin. So that's what's safer for you to compare it to the vein, exchanging any wire, any needle there. So that's really that we taught our fellows that way. But you don't have to if you don't want to. Okay, keep going down. So here's the important anatomy here. You have to keep in mind the left brachiocephalic veins are anterior to the SVC. Make sense? Because the chest coming from above and then coming to the SVC, the more posterior structure, that means as you coming out of the key, you gotta rotate slightly clockwise forward in order to get into the SVC. Then you will see sudden jump. Now, keep going there. Okay, now this is important now. When you're dragging here, for the first time for you guys to do, when you next structure to the SVC, what do you have in CT? Ascending aorta, right? And then SVC here, ascending aorta here. So ascending aorta going to be more anterior leftward than your SVC. Okay? So when you come up, drag the slide posteriorly, SVC is very soft vein. This is not a hard vein. Transeptal is going to shape the SVC like a tinting it. So if you rotate it gently clockwise, counterclockwise, you will see suddenly the jump out of that tinting. And then you go counterclockwise, it's going to go to the aorta, then you feel the aortic pulsation. So you go back to that maximum tinting to the leftward, follow that line gently. So you're hugging the posterior border of the aorta. That's why you don't make a mistake with the aorta. If you don't know where the aorta, then you should do that, find out what it is. Every patient different, okay? There's no single patient same. Other thing that we underestimate quite a bit is physical examination, chest X-ray. When you want to do this, especially in your country, you don't have intracardiac echo, you don't have none of those. If a patient has, let's say, that flat back syndrome, lordosis, the English lord back syndrome, your left is going to be deformed. So you're not going to be able to do this normal technique. Similarly, kyphosis, scoliosis, all this is different. So you examine your patient first and chest X-ray. That's very helpful. Okay, keep going down. Okay, here he mentioned very important point that the transeptal needle and the CS and RAV are moving together, synchronized, right? Remember we talked about ablation the same way, all the same way. Now, if you in this position, slightly, very slight, gently rotate anteriorly, counterclockwise or clockwise, you will see that motion range become bigger than other spot. That is the thinnest portion of the membrane. Because what you see here, the motion is due to left atrial contraction, pressure. So therefore, the needle motion, transeptal needle motion, one spot can be bigger than any other spot. That's the thinnest spot. So if you're going to do double transeptal, you want to do that first one there. That's the center of the posterior value. From that point, you go posterior to that sheet, anterior to that, what we talk about anterior puncture, posterior puncture. Okay, that is how you do it through X-ray. Okay, keep going. So this is just forget this image, okay? His orientation is perfect. So in X-ray position for transeptal would be CS coming at you in RO, LAO, his bundle coming at you, his bundle catheter. Therefore, two catheters is important for transeptal, like any other SVTA than RT case. Keep going. So you were talking posterior is not that posterior. You're talking about maybe 5 degrees or less, okay? We're not talking this big motion. Okay, keep going. Keep going down, being good. Yeah, so you know where you want to go and then up to you. Now, in my case, if I want to go to the RITV, which is more posterior vein than usual, I want to do more posterior puncture. I don't want to do anterior puncture. Because if you do anterior puncture, you have to come around, turn around. That make it very difficult to manipulate your catheter. Okay, so it should be a little lower and posterior, RITV, posterior RITV. Look at the CT scan and it will tell you, and then so on. So most common reason that the atrial fibrillation ablations and posterior septal catheter ablation failure because it's transeptal is too anterior. You cannot engage the catheter into that thing. So that's the reason. Okay, keep going. And here, I think you can inject the contrast, you can do the pressure, whichever you want. Keep going. Keep going. Now, there's one more thing that you want to see. Look at this picture, okay? And then he went through that, and then watch it, end the floor. What happened with the sheet? Rose. If you're not in the atrium, that sheet doesn't rise. It's there, because it's stuck in the tissue. Do not flush, pull it out. Okay, because you flush into the tissue, you in the septum somewhere, wrong place. Okay, worst you could do is try to aspirate a little bit, so blood comes out. Invariably, blood will not come out. You're wrong that space. So do not. So Important to watch that at the end of a sheet coming off, sheet rise, you're almost sure you're in cavity. Okay? All right. The minor detail that you saw often misses it. Other than that, I think it looks pretty good. I think you give a good talk and hopefully you guys enjoyed. Anybody have any other comment? So 2D transeptal is a standard. IC is abnormal. That's like tell my dog. Okay? You should be able to do transeptal any way you want. If you're gonna do AF ablation, BT ablation, anything you want to do. Because you perfect this technique, you know, if you go to approximately second, third world country, you better know how to do X-ray. That's why I have many fellows from US come to third world country, they don't know how to do transeptal, taking them over the left side pathway. This is a problem, serious problem. So that's what I'm telling you. So I'm glad you guys did the transeptal well and then do all the steps, so it is a very good thing.
So
Okay,
the average of the long axis of the fossa of this is 2 centimeter.
what about quarter dollar coin size was slightly smaller. Now, I give you one advice that you will face one of this patient. Patient does never had the transeptal procedure. And then you look at the intracardiac echo, you guys can see now, but before we can able to tell. Patient have a lipomas septum, that is a superior process of fat tissue embedded into the, also the margin. You're gonna have a 15 millimeter thickness there. Very difficult to blend.
At the beginning of your
Yeah.
slide, you showed the LA and your
Yeah.
RA, that patient looks like have a lipoma.
Yeah, partially lipomatosis. Yeah, so those patients that you need to really pay attention anatomy, okay, right there. So sometime maybe 2D echo you can see visualize that a little bit. But one of the signs that you will see, patient P wave is like a mitralis, P mitralis. Because intrator conduction delay lack of vacuum bubble. Those patients don't have vacuum bubble. Okay? So when you ablate those patients, septal and IVC, you need to be careful. They can dissociate atrium completely. So those are fluid that sometimes we see. So I think it is, and then other cardiac. If you do multiple transeptal, get difficult each time because it get thicker from scarring from your previous transeptal. Okay? Just be aware of that. So next time you gotta push a little harder to go through. But with the confidence, you don't worry about the, I'm gonna make a hole, yes or no, all this, no. You're determined to do, get done. Push up, engage a dilator first, very carefully, and then push through quick. Then you're gonna pierce through. Often people cannot go through because they are afraid that I'm gonna make a big mess, so they have gently. Now, when you're pushing the needle, you gotta push it. If you look at the tip of transeptal needle, it's not that sharp, it's kind of a dull. Have you touched that? It's not ordinary needle. They made it purposely dull. So sometimes you have to kind of sharpen up your needle. You have to using several kinds, especially third world country people. So sometimes they bring me a transcendental needle, they're almost like a stick. You just can't pull through. So just be aware of that. Okay. Don't do that.
Like the sphere,
I don't know.
gently, the tender, fossa and the gently.
When you tint it, even you push it hard, you can only go, what's the needle tip? 10 millimeter? You got plenty of space, unless you're tinting all the way to the lateral wall. But I can tell you, if you poke the aorta with that 21 gauge needle, nothing happens. Even no matter where you poke it. Okay? Therefore, you poke the left lateral wall, you think it'll bleed for 21 gauge needle? No, doesn't bleed. Unless you put a dilator through, shit through, that bleed. So it is a risky procedure. But it's just there's some safety margin. I know he's nervous, but so he does that a lot of
Because
times.
the patient is not his own.
So anyway, it has to be understand the anatomy, assess carefully by dragging the needle gently, slowly. Don't drag that fast. As you come into the second crevice, or once you pass the first crevices, then drag very slowly. Then you will see much clear jump. When dragging too fast, that speed don't let you engage it quickly. Once you jump it, you push the whole case slightly in, so keep the pressure. Otherwise, your needle comes out. So, other than that, it's pretty straightforward. Okay,
If you get if you go training in Severance Hospital, you cannot make such kind of very rare complication.
what makes us cannot make a work?
The aorta puncture.
Why, are you gonna fire the guy or what are you gonna
Vanish.
I believe
Vanish.
do? Are you training people, man?
But the most common mistake by fellows is when you push the sheath after puncture, if the sheath tip is located like that, okay? So sometimes the tip of sheath is rubber made. If it is broken when it passes through the skin, probably the sheath jump out and
It's
touch there.
what happened, yeah,
Yeah.
you need to think about this. You gotta curve this, you're holding the ground, you trying to push against this hole. So your needle traveling a long way from IVC to get there, so they're flexible, okay? So you push it, likely what's gonna happen, you're gonna bend, then dilator and needle comes out. So key that to pay attention to the needle, obviously your needle is pulled back to dilator already. Keep looking at the dilator, when you're pushing it, make sure they don't come back out. So keep form pressure. Now, another tip is that if you cannot advance the sheet over the dilator, you twist the thing a little bit back and forward, so that you make a hole a little bit larger than this pops in. Okay? Don't try to force it, issue, because,
Unexperienced fellows remove the dilator, not push the sheath.
yeah,
That makes.
yeah, so, but you can always get back in, so not to worry about those. Those are minor things. But it is important to remember that your needle is flexible. Because also he talked about curvature of the needle. And luckily us, we have a his catheter, right? If you look at the area view, look at how the his catheter goes. You go to the lateral of the IVC, then trajectory toward the tragus valve. So that is a good distance measurement from how much needle you want to curve it. You see that his catheter right there? So the IVC, look at that's a junction point to the his bundle. Tragus vanillus. You need that much curvature to engage into postal body. That's a good measurement. So area view always tell you, oh, I have to shape it more, shape it less. Okay. Now, other questions often asked by angioplasty or mitral valve plasty guys, they ask us, hey, how should I puncture mitral valve stenosis patient? If you have a high left atrial pressure, your left atrium is a football like stretched and the bulging to the right, not the left. Normally the other way around. So then your needle needs to be straighter because you're going to come up from IVC, lateral, you're just going to function straight up. Otherwise, you need to keep buckling. You never get to the right spot. Never engage the spot that you want because your fossa valley no longer has that anatomic delineation. It's like a bulging like a balloon. So then your needle should be straighter, open, then come up straight, slowly engage, never. So once you see the anatomic position, then just pop the needle, then you go right through it, no problem. So those things are sort of a trick that you have to think about it, hemodynamic, anatomic correlations, and so forth. Okay. So lower the pressure, normal patient, they tend to more to the left. Higher the left atrial pressure, it's the opposite. Other way around. Okay. A lot of time we think, oh, big atrium, left atrium, we got to make a bigger curve. No, that is actually the opposite. That's what I'm telling you. Any other question? Thank you. Have a good Saturday weekend. Thank you very much. Thank you, guys.
아, 예, 했습니다.
어, 됐어?
네.
Oh, sorry.
Several slides.
진짜 딱 두 개만 했는데.
Okay, let's take a look.
This is a AV NRT case
Yesterday case.
from yesterday. This is, as you can see, this is when we started ablation. So
Share the blessing. Okay.
yeah, ablation on. So the thing that we were curious about was his catheter is anatomically in his area, as we typically think. And the ablation catheter is at the typical space, not anatomically typical space. And we are curious about this signal,
Well,
which corresponds to the signal in the ablation catheter, but the distance is very long and anatomically from here. Maybe this. Yeah.
Fluoroscopic here. Okay,
Very interesting.
so you have X-ray imaging, I think you should see,
원장이 떠있잖아요.
그렇죠.
you should see the signal just before delivery energy. I think that once you start burning, you already
녹화를 꺼야 돼.
kill that thing, so it really doesn't help us.